I am the IV pharmacist over at FAMC. For my job, I run with the IV team. I review patients' charts just to make sure patients are on the right antimicrobials, are potentially stopping antimicrobials. But one of my favorite lectures or to talk about is antifungals. So this lecture is a little lengthy for things that I repeat a lot or you'll see on the Menti questions. Those would be things that you'd want to star while you're taking notes throughout this exam for your test later. If you have questions, please just let me know. And then bear with me for the technical delays I'll probably have switching back and forth from my PowerPoint to Menti. But also, in a true fashion of my lectures, I like to have it interactive. I'm going to be throwing candy, so stay awake in advance if I hit you with the candy. Sorry, don't see me. So we got Snickers, M&Ms, and some milk toys. So we'll go ahead and get started. So the objectives today, we're going to select appropriate antifungal medications based on patient-specific factors and comorbidities. And then we're going to describe the following for antifungal medications. So their mechanism of action, clinical use and indications, significant adverse reactions, contraindications, interactions, different routes of administration, and then major counseling points that you'll need to know. So for fungal overview, we're going to have another word is mycotic infections or fungal infections. And we have an increasing number of fungal infections due to increased broad spectrum antimicrobial use. So we wipe away all the bacteria, and that has the fungus ability to replicate and grow, and then as well as increasing number of immunocompromised patients as well. So these patients are at higher risk because they don't have a normal immune system to protect them from these fungal infections. With this, most fungal infections rarely cause disease in immunocompromised hosts. Usually they're just normal organisms that you'll see on the skin. However, there are some concerns. Sometimes cultures will take a little bit longer because they take a long time to grow compared to bacteria. And then susceptibility testing will take longer as well. And sometimes we don't have certain breakpoints or susceptibility testing for some of our fungal infections, which makes it a little bit harder. So we have different types of fungi. We have mold, yeast, and dimorphic. So with mold, they grow in long filamentous hyphae, and that's going to be our top picture there. Yeast is going to be the most common thing that we talk about today. The most common one that we'll talk about is Candida. And this grows as single cells that are reproduced by asexual budding, and that's going to be the bottom picture. And then we have dimorphic. So that means they can be mold and yeast. It just depends on the temperature that they're currently in. So the different types of molds, we have Aspergillus, Mucormycosis, Fusarium. Dimorphic, we have Cocci, Histoplasma, Blastomycosis. And then like I said with yeast, we have a lot of Candida species. So the most common one that you'll see in practice is Candida albicans. And then for our non-Candida albicans species, we have Tropicalis, Glabrata, and Krusei. So with the last two, we kind of think that fluconazole is going to be our pure treatment. However, for these two organisms, they have intrinsic resistance and increasing resistance to fluconazole, so we have to use other antifungals to treat them. And we'll go over that later. Give me a second. All right. So again, most common fungi is going to be our Candida. So risk factors that patients will have for Candida infections will be prolonged neutropenia, if they had a recent abdominal surgery, because that's a common place where they live. So if you manipulate the gut, you have potential to cause infection. Again, like we said earlier, broad spectrum antimicrobial therapy. Presence of intravascular catheters, so like if a patient's on HD and they have a tunnel cath, Candida really likes to stick to things that are foreign or hardware. And then lastly, IV drug use. Bear with me, the computer's a little bit slow with advancing the slides. So with our fungal infections, we have different types. So we have superficial, and this is caused by dermatite fungi. And think of this as more superficial. So it's going to be infections of the skin, hair, and nails. And then we have mucocutaneous mycoses. So this is going to be more so diaper rash, oral candidiasis, or vaginal candidiasis. We also have subQ mycoses, and that's going to be more so involving the skin with the dermis, subQ, and the muscle. And then we have systemic mycoses. So this is probably the most common one that I see in my practice. So these are going to be infections of the organs and tissues, so causing UTIs, meningitis, bacteremia, intra-abdominal infections, and things like that. So when we think about the antifungal structure, we want to kind of realize it's going to be a little bit different from our bacteria. So fungal cell membranes contain rigid cell walls composed mainly of chitin. And another important thing is that fungal cell membranes contain ergosterol. So compared to mammal cells, that's going to be cholesterol. So for our fungal species, remember cell membrane is going to contain ergosterol. And then this is where our antifungals act upon that protein to kill our fungal infections, except for some of our antifungals like flucytosine. So as you can see here, we have tons of different antifungal agents. So today we're going to go over all of these. Some of them I'm going to go over quickly because a lot of the information is kind of repetitive, and then things that I'm not going to have you worry about for the exam, we'll kind of highlight those as well. So this picture right here is just an overview of while you're studying of the different types of antifungals and where they work on the fungal cell. So first up we have our polyenes. So the mechanism of action of polyenes is they selectively bind to the ergosterol in the fungal cell membrane. And what happens is this disrupts the cell membrane, which causes depolarization of that cell and causes leaks, which causes cell death. So you can see right here, this is where it's going to be acting on. So the most common polyene that I use is amphotericin. So this is going to be one of our biggest guns antifungals that we use in clinical practice. So this is metabolized in the liver. It's renally excreted. We have a half-life of about 24 hours and a terminal half-life about 15 days. For the formulations, we do have topical, intrathecal, and IV. There's no oral formulations that are currently approved by the FDA, but there are some tests, current clinical trials of oral amphotericin. But again, right now, the most common one we're going to see is the IV formulation. With this, we have different types of formulations, so we have to be very specific which one we're picking. And we'll talk about that here in a couple slides. So when we think of amphotericin, we think of broad spectrum coverage. And with this being fungicidal, meaning it kills the fungi. If it was static, only hinders the replication of the fungal cell. So with this, it covers Candida, Aspergillus, Mucorblastococci, tons of different things. We have limited coverage of Candida auris, however that one's not that common. And we have to think about some gaps. So there are some Candida and Aspergillus species that are not covered by amphotericin, and that's Candida lusitania and Aspergillus terreus. So as I was saying earlier, we have different types of amphotericin B. So we have the deoxycholate, which is the conventional formulation, which is fluindazole. We also have the amphoteric and abelset, but we really won't discuss those today because those are not as used as commonly as the conventional and the ampazone. So the amphotericin B liposomal is the one that I currently use most common in practice here, and we'll talk about why in a couple slides. But we really want to be mindful that these formulations are not interchangeable and they have dosing recommendations depending on the fungal infection and the indication. So when we think about amphotericin B, the two big ones I want you to think about is the conventional and the ampazone. So the ampazone one is the liposomal one. And what's awesome about this one, it's designed to have less side effects. So it's sequestered by cells in the reticular endothelial system in the liver and spleen, which slowly releases amphotericin into the circulation over several days rather than doing it right away. So this more slower sustained response helps decrease our side effects of infusion-related side effects, nephrotoxicity, and then as well as infusion-related side effects. So like we stated, there's different formulations, but again, the most common one that we're going to use is the IV formulation. So with amphotericin, we kind of think of this as amphoterrible because there's tons of different side effects. So like I said earlier, we have numerous infusion-related side effects. So this can occur 1 to 2 hours after starting the infusion, but it also can occur during the infusion as well, and then with repeat doses. So things I want you to remember is that we need to pre-medicate our patients prior to getting amphotericin to help lessen some of these side effects. So we want to pre-medicate with acetaminophen, does not cause autism, antihistamines, and then some steroids, and then as well as some boluses of normal saline pre and post infusion to help the patient's kidneys. Again, the biggest thing I want to highlight here is that liposomal is going to have the least infusion-related side effects because of this formulation. So again, when we're starting to dose amphotericin, we need to make sure that we have the right formulation and then know what our indication and fungal species is that we're worried about. So the usual dose of amphotericin is going to be 3 to 5 mg per kg based on the patient's actual body weight. Sometimes for more severe infections, like central nervous system infections, we're going to use higher doses up to 10 mg per kg, depending on what kind of fungi it is, to make sure that we're doing appropriate killing. And then the amphotericin B-deoxycholate, again, this is going to be our conventional amphotericin. This one's going to have the most side effects. With this, that's one of the most reasons why we don't use it anymore. Also note that this dosing is highly different compared to the one above, where it's just 0.5 to 1 mg per kg per day, with a max of 1.5 mg per kg per day. And the only time I ever use this is when we have a fungal infection with the UTI.
Ma'am, question.
Yeah.
When you were talking about pre-medicate, you want to pre-medicate your patient all of these antipyretics, all of them?
So usually it's Tylenol, Benadryl, and then pre and post fluid boluses. Depending if they have Rikers, you can add on the meperidine, but kind of depends on what kind of side effects, but usually the Tylenol, the boluses, and the Benadryl. So again, we stated nephrotoxicity is a common side effect, and also we need to monitor our electrolytes. It can lead to significant wasting of magnesium and potassium, so we always have to get CBC to make sure that we're giving resupplementation appropriately to our patients. We have anemia and then seizures, but that's only with intrathecal dosing where they're instilling it into like the spine or the ventricles. Again, other things, fevers, chills, rigors, headache, nausea, vomiting, and then looking at your CBC with your white count and platelets and things like that. And again, we talked about that. And the cardiac arrhythmias is more so for the conventional dosing, but you don't have to know that one. So now we're going to transition over to the other Pauline, and this is going to be nystatin. So this is kind of completely different compared to amphotericin, but we still have the same mechanism of action. And this is going to be used topically or oral for oral infections. So the most common area that we're going to see this is for thrush, and what we're going to do is we're going to retain that PO as long as possible and then swallow. Other times we'll use nystatin is for cutaneous or mucocutaneous candidiasis, yeast infections, and as well as dermatitis in pediatrics. So what side effects with nystatin? It's pretty minimal compared to amphotericin. Again, with the oral administration, you might see some nausea and vomiting, and then potential skin irritation with some of the topical formulations. So now we're going to transition over to Menti. So go ahead and go to menti.com if you haven't, and then type in the code to 8258 4364 to play, and then give me a second to figure out how to transition over to that.
8258.
82, oh sorry, let's go back. Okay, can you see that? How do you do that?
8258 4364.
The last one I said, everything else I was like, species and everything, just us doing what they like. So different.
Oh, like the pre-show?
I will. I'm finding it
Alright, perfect. Okay, and this is where I'm cautioning there will be candy thrown in the air, so please stop if it's headed in your direction or location.
If you need the code again, it's up there at the top, 82584364. I'm expecting to see more than 28. Is everybody logged in? Yes?
Oh, that's just my question. We got 63.
63? 65?
Alright, so for this, if you answer correctly and quickly, you get more points. And then, yeah, we'll give a little highlight to the winner at the end. So we'll go ahead and get started. Alright. So which fungi is classified as a yeast? I don't know the first one, but we have Canada, Fusarium, and Eucor. Keep your blood pressure up. Alright, perfect, Canada. Can someone tell me what Eucor is? Is it mold, yeast, well it's obviously not a yeast, or dimorphic?
Both.
Oh, I love it. Alright, I heard, watch out. Alright, perfect.
I'll take those.
Wait.
Alright, so this is what will happen periodically. They'll show the leaderboard here. Alright, so we have ET in the lead right now. Alright, next question. True or false? Fungal cell membranes contain rigid cell walls composed of chitin.
Y'all can't handle myself.
True, yes. And then the next question is going to be, I believe, again about the structure of the fungal cell. Yes. Fungal cell membranes contain what? Yes, cholesterol. Remember, cholesterol is going to be bad. So remember those two things, chitin and cholesterol, okay? Which antifungal is a choline that selectively binds to ergosterol in the fungal cell membrane? Hint, we only talked about two, so that should give you a hint. Perfect, amphotericin B. Can someone give me some formulations of amphotericin? Say it again aloud.
Liposomal?
Yeah, we got liposomal,
Conventional?
conventional, love it.
Y'all some good catch.
And the other ones I didn't really emphasize, so that's all right.
Control.
Alright, true or false? Amphotericin B is a broad spectrum antifungal. Don't let me down. Yes, true. So think of amphotericin as going to be the biggest gun for antifungals. least side effects. Antifungal, sulfate, lipid complex, liposomal. I probably got to with the lipid complex. So the lipid complex would be like in the middle of the conventional and liposomal with the reactions. And I think the next question should be about some side effects. Oh, never mind. Statins commonly used for what? Love it. So oral psoriasis. Going back to amphotericin, can you guys give me some side effects? Toxicity. I heard something over here.
Eddie.
Love it. What about the and perfect. Go down. What kind of person peanut butter M&Ms? I did write this. Alright,
What's that one? What is the class leader?
I love it. Well, that's going to be great because I think we're going to talk about azoles next.
Hey, guys,
Alright, perfect. So, like I said earlier, we're going to transition to azoles, and this is going to probably be the most common antifungals that you guys will use in practice. So with our azoles, they're inhibited by synthesis of agrosterol by blocking the linastrol 14 alpha demethylase, which that means it just inhibits the fungal cell membrane, increases permeability, aka leading to cell death. For this, increases affinity to inhibit fungus CYP450 enzymes rather than the familial CYP450. And this is progressing ahead, right? Perfect. Okay. So we have a lot of different types of azoles. We have our triazoles and our imidazoles. With this, it's just differences in structure. So we have 3 nitrogens for the triazoles and then 2 for the imidazoles. So overview of triazoles, we have good bioavailability. We have a lot of drug-drug interactions, but most of them. We have hepatotoxicity and QTc prolongation that we need to monitor when we place our patients on these. Again, with this, they prevent the conversion of linastrol to ergosterol. With our triazoles, no 2 triazoles are the same. So their PK/PD profiles are different. So that's kind of what makes them hard when we think of like counseling our patients and with different formulations when we prescribe these. Also, depending on our triazole and our indication, we have to do therapeutic drug monitoring to make sure we have therapeutic levels that are killing the bacteria and our patients are not having side effects from potentially low or high levels. And then as well as they do have some risk of being toxic to our pregnant patients and babies. So some of these, especially when we get to some of our topical formulations and vaginal penises, you'll hear me say a lot topicals over orals because of this factor. So with our triazoles, they distribute in the tissues and body fluids. Fluconazole is great. It has great concentrations pretty much everywhere in the body, including the central nervous system. Again, the GI absorption is going to vary on the triazole, but we'll talk about that. but specifically with itraconazole, posaconazole, we need an acidic environment to increase that absorption. And then again, they can be fungostatic or cidal depending on the fungal species that we're using it against, and again, why we have to do some of our drug monitoring. It's excreted in the urine and feces, and again, we're going to use these for our serious systemic infections. So first, we're going to start with itraconazole. For this, the biggest thing that we're going to use itraconazole in practice is step-down therapy for blast or histo. Another thing that's going to be common is onychomycosis, which is going to be fungal infection of the nail. And the reason why we use it in nail infections is because it has very high concentrations in the skin and tissues compared to the other azoles. With this, we always want to run drug-drug interaction. Yes?
Is that the one that's white and fluffy,
White and fluffy.
like the nail?
Yes. And then for this, anytime we use this, we want to do drug-drug interaction reporting. And then a big thing that we want to think about with itraconazole is we want to avoid in patients with congestive heart failure because it can make their heart failure worse. So, for formulations, it's only oral, there's no IV in the US. And with this, we need to be mindful of what oral formulation we're picking because they're not used interchangeably. So we have different dosing for different things and different counseling points. So the solution is preferred over the capsules just to better absorption. We don't have to worry about the gastric pH, and then as well as we can give this on an empty stomach. With capsules, it's going to do the opposite where we need to take it with food or acidic beverage like cranberry juice or soda to increase that absorption. Also, we need to think if there are any other medications that will decrease that acid suppression, so our PPIs, H2RAs, antacids, things like that. Next is fluconazole. So again, this is going to be the heavy hitter in our azole class. We have great oral bioavailability. For this, with or without food is okay, but if we have, we don't need an acidic environment like the last one for better absorption. Again, it concentrates well in various parts of the body, and we have renal excretion, which we need to renally dose for our patients. With this, we have tablets, as well as a suspension and an IV formulation. So with fluconazole, we have different spectrum and clinical use that we have. We have Cryptococcus, cocci, and the most common one that we'll see is Candida. With this, we do have to be worried about certain Candida species like I talked about earlier with Candida glabrata because we have increasing resistance. With this, we need to use higher doses of fluconazole just so we have more penetration in that fungal cell wall for Candida glabrata. So the usual dose is usually 200 to 400 depending on their indication, but this we usually use 800 milligrams or more in clinical practice. And then we need to avoid using it in Candida krusei. I always teach no food for the crew because this is intrinsically resistant. So Candida krusei cell wall is different compared to Candida species, so that fluconazole doesn't hit that target enzyme to do its killing. So it doesn't link up. So other things we need to think about too is fluconazole is not going to be used for any other molds, so like Aspergillus, Mucorn, Fusarium. With side effects, again, with a lot of antibiotics, you'll hear all the GI upset, nausea, vomiting, diarrhea, potential headache. We want to monitor for QT prolongation and elevations in our liver enzymes. For this, oral fluconazole is going to be the treatment of vaginal candidiasis. Again, it's not going to be recommended during pregnancy. You'll see this again and again in future slides. Causes fewer drug interactions compared to the other azoles like voriconazole, itraconazole, but we do have some drug-drug interactions that you need to be worried about. So like warfarin, phenytoin, things like that. So voriconazole, this is a little bit different compared to the other azoles, is because it exhibits nonlinear kinetics due to saturation in its metabolism. Meaning with this drug, we have to do a lot of therapeutic drug monitoring to make sure we have therapeutic levels. So any slight changes in the dose can cause huge differences. So when we change the dose, we do maybe 50 to 100 milligrams increase or decrease, not like double because it can affect the patient's levels and cause potential toxicity. With this, the biggest thing I want you to know for voriconazole is it's gonna have a lot of drug interactions and a lot of side effects. For the drug interactions and contraindications, I'm not gonna quiz you on, it's an inhibitor, substrate, all that. Just know you'll always do a drug-drug interaction report before starting this. So with this, it has enhanced activity compared to fluconazole. So this is gonna hit Aspergillus, which is one of our molds, as well as Candida. With this also covers Candida krusei, and this is gonna be our drug of choice for Aspergillus. So again, drug of choice for Aspergillus. With the formulations, we have oral tablet, suspension, and IV. We have great oral bioavailability, and again, doses can either be on a fixed dosing schedule or mg per kg. So sometimes we use 6 mg per kg for a loading dose to get them to steady state quicker, and then a maintenance dose of 4 mg per kg. Or depending on what it is, we can do 200 to 400 milligrams.
Just to confirm for the food,
Fluconazole, yeah.
console, the statin can also be used for
Fluconazole for vaginal candidiasis? Is that the question?
You can also use the statin too?
Yes, yeah. Yeah, so fluconazole is gonna be more so if you can't do like, or they feel like topical therapy and things like that. So voriconazole, again, biggest things, drug-drug interactions and a lot of side effects too, like amphotericin. So think of V for visual. So we have potential neurotoxicity, visual hallucinations. Patients can complain about transient visual disturbances, they'll have blurred vision, photophobia, they might have altered visual colors and perceptions. So think V for visual side effects. Also, it can cause phototoxicity and rash if it's on for long-term use. When it's used for prophylaxis in some of our immunosuppressed patients, they have a higher risk of skin cancer and melanoma. And also, again, with longer durations of therapy, it can cause hair loss. And then, as always, a lot of LFT elevations with voriconazole as well. Next up is posaconazole. Oral bioavailability varies again depending on what formulation you have. We have a half-life about 28 hours with fecal excretion. With this is going to be used again for Aspergillus and Candida. It has some expanded activity and also covers Fusarium and Mucor, which is other molds that we're concerned about, especially in our immunocompromised patients. And again, you'll see posaconazole used a lot in prophylaxis in our immunocompromised patients. This right here is just a graph showing that we need to be mindful of how we're taking posaconazole. So with this, a high-fat meal increased the posacona absorption for our patients. So it's always important to counsel that they're taking that depending on what formulation we have. So again, that suspension needs to be given with meals or acidic beverages to increase that absorption. However, tablets are a little bit easier to administer, and it's better absorbed, tolerated, and easy to administer. So usually we'll use the tablets a lot more compared to the suspension. Some of the adverse reactions to this, again, are going to have those GI disturbances, of nausea, vomiting, diarrhea, and then hepatotoxicity. So again, any azole, we want to watch out for those drug-drug interactions. Again, we want to be mindful of drugs that can alter the gastric pH. And then again, we have various inhibitors of CYP, inhibitors and substrates. And then again, we want to avoid statins because it can lead to rhabdo with those patients. Next up is isavuconazole or Cresemba. So this is one of the newer azoles. With this is a prodrug. So it's isavuconazonium sulfate, which is 186 milligrams. With this one's actually really cool because it has a way different profile compared to the other triazoles. So with this, there's no renal adjustment compared to like fluconazole. And then as well as there's way less LFT elevations with isavuconazole. There are some drug-drug interactions, but not as much as other azoles. And then the other thing that is different compared to the other azoles is this actually shortens the QTC rather than prolongs it. With Cresemba, this has an an extended spectrum, so not only does it cover Candida species, but also can cover molds like Aspergillus and Mucor. So for this, we'll use this a lot too as either prophylaxis in our immunosuppressed patients or for broad empiric therapy or some of our more invasive fungal infections. With this, we both have oral capsules and IV formulations. With capsules, we can take it with or without food, but with this, again, we don't want to open, chew, or crush those capsules. Right here is just an overview of the various antifungals, their formulation, bioavailability. This is not something that you'll need to know, this is just an FYI for you guys. And then same with this slide right here, it's just giving you an overview of the various antifungals and then what fungal infections it can cover. Same thing, you guys don't have to worry about this, it's just more for FYI. So next we're going to talk about the other class of triazoles with ketoconazole and clometrazole. So with ketoconazole, this is going to be topical. With this, it's not going to be significantly absorbed since it's topical. We have creams, foam, gel, and shampoo, but the oral formulation we'll not discuss because the majority of these are you're going to use in the outpatient setting for topical use. So we have the 2% cream, and this is going to be treatment for some of our tinea infections or like ringworm infections. And also it's going to be used for dandruff as well. With clotrimazole, again, this is going to be an oral formulation. It remains in the saliva for 3 hours after you have that dose. We have troches, lozenges, topical creams, and solutions for this. Again, this is going to be a lot for tinea infections and potential cutaneous or vaginal candidiasis. We also can use it for oropharyngeal candidiasis, for treatment or prophylaxis, and we'll talk about that a little later on. With monitoring the side effects, we can monitor potential hepatic function with prolonged use with this. Next, we're going to transition to the alamines. So with this is going to be used for superficial dermatophyte infections. So we have terbinafine, naphthene, butanafine, and a lot of these are going to be the mechanism of action with fungal cell membrane inhibitor. So it inhibits, again, that ergosterol synthesis. So with terbinafine, we have a bioavailability about 40%. We can give this with or without food. And this is going to be the major thing that you're going to treat is for fungal infections or tinea capitis. But again, we don't want to use this in pregnancy because of their potential side effects for that fetal harm. Again, with breastfeeding, that transmission, we want to avoid. With this, it's distributed in the skin very well, but we do have to monitor renal function with this since it is renally dosed. We have oral tablets as well as topical creams and solutions. So for clinical use, again, it's going to be for those tinea infections. So for the oral dosing, this is going to be first line, and just think with this, it's going to be a long duration of therapy. So for infections of your fingernails, you're going to do it daily for 6 weeks, and then think for your toenails, double that with 12 weeks. Topical dosing for tinea pedis, corpus, crucis, and versicolor, and cutaneous candidiasis. It's going to vary with 1 to 2 times a day for 1 to 2 weeks, so a little bit shorter. With adverse reactions, we have headache, rash, diarrhea, nausea, potential taste disturbance, and again, potential for liver dysfunction, so potentially monitoring our LFTs at baseline and during treatment, especially if we're on that 12-week course for toenail infections. Next up, we have naproxen, and this is going to be used for topical use only, and this is going to be a gel or cream. Again, for tinea infections, again, topical treatments for various tinea infections, and with this, duration to 1 to 4 weeks. You might have clinical resolution quicker with a higher formulation with the 2% compared to the 1. All right, we're going to switch back to Minty now. Yes. 2843.64. Yeah, no, that's,
Okay, take your break and then come back. So 11 o'clock. I paid that much, I did not pay that much. But now I'm trying. Somebody said, okay, come there, and I was like, so I paid.
I think maybe honestly, I feel like I was wondering why my exes like one time I should put it down. Never, I don't know it. Places you don't worry about it. I'll do your name test. Pineapple's crazy. On the Gemini Netflix. No, apparently I'm 44 classmates. Alec is 50. That's Alec is 50. It's the world Alex.
You want to talk about this form? Yeah, this is my okay, so I'm like 4 slides behind.
I know, I'm like, I'm letting you know what she's like.
I don't know, like we'll just start a slide and already the whole time we go fast. I'm like, how? I'm like 2 slides behind. I'm waiting for a second.
Alright, can you hear me? Yes, ma'am. Okay, perfect. We'll go ahead and I'll have y'all get back to menti.com and we'll continue with our questions. Just bear with me. So hold on, let's get anyone good with the internet down your hard drive server? No? Well, we'll transition back to the lecture and then we'll just do 2 rounds of NP. How's that? I know. Yeah, I did. Now I'm trying to figure out how to. Sorry, I forgot. Okay, of course I did. Why would I do that? Why? That says exam 4, it doesn't even say exam 2. Oh, then you do study, you're gonna be ready. Oh, okay. You have that. Be okay with getting out of here, okay? Alright, we are back in action. We got it. My players dropped. Ooh, what were you doing? Okay. Alright, next question. Which of the following is not a nasal? It's gonna be hard. Oh, hold on. Lock surgery. Hey! Can anyone tell me what is omeprazole? Okay, heads up. There's a lot of talking. Right there. Alright, can someone give me a side effect of fluconazole? Okay, what about fluconazole? What was the big thing for side effects I was mentioning about fluconazole?
No pregnancy. Never toxicity. No pregnancy.
So what kind of visual side effects?
No pregnancy.
Photosensitivity?
No pregnancy.
No pregnancy? So like hallucinations, they'll have differences in colors, things like that. Oh, you should go back.
No flu for the group. That's right.
Yes, no flu for the group.
That's right. That is.
Alright, which Canada species, oh my god, was this our, whoever said that? Intrinsically resistant to fluconazole. No flu for the, oh no. You get all your candy.
It's not whole turkey. I get all this. I get all this.
Yeah. And then what Canada species
He's not gonna bring it
has,
home to his kids. Not insane.
and what Canada species has increasing resistance to fluconazole where we need to use PHARM? Yes, Colorado. Who is that over there?
I think he said it first.
Next up. Which azole is a drug of choice for aspergillus?
Yes.
We were just talking about this one. This one. Side effects. Yeah, so there's the whole thing. Yeah, so voriconazole is going to be the drug of choice for aspergillus. Think of fluconazole, this is going to be for Canada. Amphotericin, this is going to be more so for broad spectrum. And then itraconazole, this is going to be more so for histo or nail infections. Alright, and then give me another side effect of voriconazole besides visual disturbances.
Alopecia.
Snickers. Alright. Which azole does not prolong the QTC?
Especially.
Yes, so I say buconazole, so Cresemba, because I say buconazole is mouthful, so this is the only one that does not prolong QTC, it decreases it. All other azoles do. This one is very well tolerated, less side effects compared to other azoles, and then no renal adjustments. Terbinafine is commonly used for the treatment of what? Thrush, nail infections, curative therapy for Candida, treatment of histo, or yeast infections. Yes, so biggest thing I want you to know about this drug is treatment of nail infections. Alright, let's see who we have in the lead. Okay, Lucan's still there. Alright, perfect. Now we're going to transition over to echinocandidates. So in echinocandidates, we have 4 different types. We have mycofungin, angulofungin, phosphofungin, and rosafungin. For this, their mechanism of action is inhibiting the fungal cell wall synthesis by inhibiting beta-1,3-D-glucan synthesis, which leads to cell lysis and death. So an overview of the echinocandins. The majority of them are once daily dosing. This is IV only. With this, we don't have to worry about any renal adjustments. We have minimal drug interactions. With this, we think of infections for intraabdominal infections with great penetration into the lungs, liver, and spleen. And then one thing that we really have to think about when we're treating our patients is avoiding these for patients with CNS infections, UTIs, or eye infections, because the echinocandins do not achieve adequate concentrations to kill the fungal infection there. So for clinical use of echinocandins, I want you guys to think that this is going to be our empiric therapy for ICUs for Candida infections, okay? With this, we have, again, most Candida species. This does include treating Candida krusei and glabrata. Again, remember fluconazole, we have problems, but with our echinocandins, we do not. With this, we want to have caution with some of our aspergillus species. This is more so for salvage therapy or combination therapy, just because it's not cidal against aspergillus, it's only static. And then for this, think again, this is only for Candida. We can't use this for our mold species and our endemic fungi like our histoblasto. With this again, very well tolerated. We use this a lot in our ICUs over at BAMC. Again, just because of its tolerability, less drug-drug interactions, things like that. We do have to monitor LFTs, but it's not as bad as the azoles. And again, you'll still have some of those GI side effects. So breaking it down into the various echinocandins, first we have caspofungin. For this one, we do have to dose adjust and monitor moderate hepatic dysfunction. We do have some CYP interactions. With this, we have a half-life about 30 to 50 hours, and it's excreted in the feces and urine. Again, we don't want to use this in pregnancy for concern of fetal harm. And then it's a semi-synthetic product of a fungus, but you guys don't have to need to know that, just more so a fun fact. So micafungin is the most common echinocandin that we use over at BAMC. For this, again, no renal hepatic impairment or dose adjustments, not a big CYP substrate. So again, I'm not doing any drug-drug interactions. Patients are studied on micafungin. We have a half-life of about 11 to 21 hours in adults. Biggest things again with this, avoiding in pregnancy. And then again, echinocandins are going to be used for empiric Candida coverage. Andulafungin, again, same like mica, no renal hepatic impairment with dose adjustment. Again, not a lot of drug-drug interactions, excreted in the feces, and again, it's pretty much the same slide here as mica. Again, with the echinocandins, it's kind of going to depend on your hospital's formulary and which one they will carry. Usually it's just one of the echinocandins. And resifungin, this is one of the newest echinocandins on the block. It was approved back in 2023. And what's really cool about this is that it's only dosed once weekly because it has a nice long half-life. So some of those others were like 11 to 20 to up to 50 hours. This has a half-life of 152 hours. With this, no renal hepatic adjustments. There's a little bit more monitoring and side effects with this, so looking at your electrolytes, and then some of the common ones that we see too with those GI upset. All right, next we're going to transition to newer agents and some other ones. For this is more so going to be an FYI, just to kind of alert you of some of the newer antifungals on the market and other things that you may potentially use. So first up is flucytosine. And this mechanism of action is a little bit different compared to all antifungals because this one interferes with fungal RNA, DNA, and protein synthesis in which it does the killing. With flucytosine, it's usually only for add-on treatment with amphotericin in our patients who have potentially CNS infections with cryptococcus, and then as well as we can use it for some of our Candida infections as well. For this, we're not commonly using this for monotherapy. However, if we are on a last-ditch effort to treat someone with a fluconazole-resistant Candida UTI, we may reach for this. However, the only thing is, it's a lot of capsules. It's 25 mg per kg per dose, 4 times a day, and it's super expensive. So a lot of the time, places might not have that in stock. With side effects for flucytosine, again, those GI upset. We want to monitor our electrolytes with our potassium, liver and renal dysfunction. Also can cause bone marrow suppression, so looking at our CBC, and then as well as having photosensitivity. Next up, we have a brexafungert. So this is one of the newer drugs on the market, and fun fact, this is actually on recall right now, so no one can get it. One of my providers was asking about using this for vulvovaginal candidiasis that was resistant to everything, and we were unlucky and found out that was on recall. be for refractory or resistant vulvovaginal candidiasis. Again, I'm gonna kind of skip over this one because we don't foresee this being back in the market as of right now. But biggest things I want you to think about with these new ones, don't use them in pregnancy. Another newer agent we have is oteseconazole. This is an azole metalloenzyme inhibitor of the fungal sterol. Again, these are going to be oral formulations for recurrent vulvovaginal candidiasis. With this, we can use with or without fluconazole, but we don't want to use it in patients who are pregnant due to the fetal harm. With this is nice because it has a long half-life. If we ever prescribe this, we want to take with food to increase that absorption, and again, not to chew, open, or crush those capsules. With side effects, patients might have headaches, nausea, hot flashes, and painful urination. So just an overview of some things that I want you guys to know. So again, echinocandins, those are going to be your empiric use for treatment of Candida, especially in your ICU settings. For candidiasis prophylaxis, fluconazole is going to be commonly used. If we can't use them for any reason, we can use echinocandins. Again, for aspergillus, voriconazole is going to be our drug of choice for that. If we can't use that, then potentially amphotericin or posaconazole. And then again, for aspergillus prophylaxis, voriconazole and posaconazole are going to be used. All right, we're going back to Menti again. Yes?
Were you saying everything from the other /new agents was FYI?
Everything, yeah, from right there, FYI. So just more so of an update of the newer agents, just in case you have to use them in the future. What class of antifungals inhibit fungal cell wall synthesis by inhibiting beta-1,3 glucan? Azoles, cholines, echinocandins, imidazole. Hey, I love it. Okay, can someone tell me a type of echinocandin? Mycofungin. I heard hexafungin. And all right, can someone tell me a choline that isn't amphotericin? Yeah, nice dad. Next question. True or false? Echinocandins come in an oral formulation. Pretty close. So, IV formulation only, once daily dosing besides resafungin, which is once weekly. That's there. molds. And then histo is endemic fungi, and again, echinocandins would target that. Alright, just said this one. Echinocandin is only dosed once weekly due to its long half-life of about 152 hours. Mica, Casco, Reza, and yes, that's the Riz. Alright, which antifungal interferes with fungal RNA, DNA, and protein synthesis? We're not going to use this one as monotherapy unless we're last line with the Candida UTI. Yes, flucytosine. True or false? Flucytosine is commonly used in combo with liposomal amphotericin B for empiric treatment of Candida with Cryptococcus meningitis. I think I just said that. Yes, it's true. Alright, Lepezaconazole and Roxafungerger are not recommended for which patient populations? To treat refractory, recurrent vulvovaginal candidiasis. Roxafungerger? Yeah. Alright, now we're going to transition to pharmacological treatment for fungal infections. A lot of these slides, I probably will talk faster and go faster because a lot of them is going to be repetitive and have the same information, but I will highlight the ones that I want you to know. Okay? Alright, we're going to start with vulvovaginal candidiasis, so I'm going to call this VVC going forward. Alright, VVC, this is going to be infections in individuals with or without symptoms who have a positive vaginal culture for Candida species. So symptoms the patient might complain about is itching, vaginal soreness, abnormal discharge, painful urination, or any pain during sexual intercourse. With this, we want to think about too that Candida is normal flora of the vaginal flora there. With this, we do have some asymptomatic colonization in about 10 to 20% of women of reproductive age. So with this, we have different classification of VVC. So for uncomplicated, it's going to be an infrequent infection, and it's going to be mild to moderate infection, meaning patient can tolerate orals, they're still stable, they're not needing like hospital admission. With this, it's likely going to be Candida albicans, and these are going to be not immunocompromised patients, immunocompetent females. With this, the goal is to have relief of those symptoms. So things that we want to consider is a lot of patient-specific factors. So in trials, oral and topical antimycotic drugs achieve comparable clinical cure rates, which had excess of 90%. So things that we want to consider is something that's over the counter versus prescription, patient preference. Do they want to take a tablet or apply a cream? The potential cost, are they pregnant? Are there certain things that we need to avoid? So again, for pregnant patients, we're going to use topicals because it's not systemically absorbed. For side effects, for topical treatments, they'll have lower side effects because of it's only absorbed locally. But again, patients might have some burning or irritation with that cream. And then again, oral medications may cause some GI upset, have side effects of headache, rash, potential abnormal LFTs. But the biggest thing is we want our patients feeling better. So oral medications may take a day or two longer since topical therapy is directed right at the site. So with this, I do not need you to memorize all these different antifungals with doses and what kind they are. Just know you have a lot of options over the counter for patients for VVC. For prescription antifungals for VVC, we have vaginal agents. Again, I'm not going to have you guys know all these different types. Just know that you have various options right here. Our oral agent that we're going to use is going to be fluconazole, 150 milligrams in one single dose. So that's usually nice and easy. The patient only has to take it one time. So next, we're going to look at complicated VVC. So with complicated VVC, how we classify this is if a patient has recurrent VVC, if it's a severe infection, if it's a non-Candida albicans species, and then patients who are potentially immunocompromised, diabetic, or on any therapy that will depress their immune system. And then with this, vaginal cultures or PCR should be obtained to confirm if it's a non-Candida albicans species. So with recurrent severe infections, we're going to have longer durations of 7 to 14-day course, depending on what antifungal. Fluconazole, we can use 150 to 200 milligrams once every 3 days for a total of 3 doses. So we'll have day 1, 4, and 7. Sometimes for suppressive therapy, we can use fluconazole as well, weekly for a long duration of 6 months. For non-albicans, usually for those, we're getting a culture and susceptibility report to help guide therapy. But we can use boric acid capsules intravaginally daily for 3 weeks, and then some of those newer agents I talked about, so the otaciconazole, and no longer arexafungerp, but some of those agents we can consider. With those, since they are newer, you're more than likely to have to do like a PA for your patient. Here, this just gives an overview of complicated VVC treatment. Again, you don't have to memorize dosage, routes, and things like that. Next up, we're going to transition to oropharyngeal and esophageal candidiasis. So with this, the approach is going to be, again, specific to our patient. We want to assess their immune status, their current disease, if there's any concurrent medications that they're on that will interact with our medications, and if they're being treated for any other infectious disease. So with mild disease, clotrimazole troches we can reach for, or meconazole buccal tablets. But the most common one that I see in the hospital is the nystatin suspension, which the patients will swallow for 4 times daily. If they have moderate to severe disease or they have been unresponsive to that local treatment, then we're going to take it up to an oral agent with fluconazole, which we get 200 milligrams on day 1, followed by 100 to 200 milligrams daily. For severe disease, duration of therapy is going to be about, again, 7 to 14 days. And if we have refractory disease, then it's going to be at longer durations of 14 to 28. So for esophageal candidiasis, the preferred antifungal, again, fluconazole. You're going to hear me repeat fluconazole a lot. So we're going to have 400 milligrams on day 1, followed by 100 to 200 milligrams daily. For any reason the patient can't tolerate any oral medications, then we're going to reach for an IV with echinocandin. And then again, 14 to 21 days for initial treatment. And then if we have treatment failure, we're going to go longer, up to 28 days. Next up, we're going to go over tinea infections. And a lot of this is going to be repeat of terbinafine. And that's the big thing that I want you guys to remember. So here we have a lot of different tinea infections. So for this is going to affect the skin, hair, nails. So here we're going to cover various tinea infections. But again, we're gonna have one antifungal that is going to be standout. So here are some pictures of various tinea infections for you. For this, like pedis, remember pedicure for feet, capitis, think of your head, corpus, think of like your body with your arms and legs. And I think manum is on there somewhere, think of like a manicure to remember like the different color or different locations. So for athlete's foot, initial treatment's gonna be daily to twice daily for 4 weeks, depending on what drug you use. You can use topical azoles, alamines, there's tons of different things that you can pick. Biggest thing for refractory disease, we're gonna reach for the oral terbinafine, 200 milligrams daily for 2 weeks, or we can potentially do fluconazole, 100 milligrams once per week for 2 to 6 weeks. Tinea corpus, again, you're gonna see the same thing populate, same antifungals that we can consider over the counter or potentially for prescription. Again, you're gonna start with like the oral or the topical OTCs, and if patients don't respond to that, then you can go to the oral tablets of terbinafine and fluconazole again. Bless you. Onychomycosis, this is going to be our nail infections. So again, oral antifungal may be more effective than topical, but you can consider topical if we're concerned with any drug-drug interactions or for patient preference. For our first line treatment for mild, moderate, and severe cases, we're going to do the oral terbinafine. And again, for infections of the toenail, we're going to do a longer duration with 12 weeks versus your fingernails are just going to be 6 weeks. For tinea versicolor, this is going to appear as hyper and hypopigmented scaly patches on our patient. They're non-contagious, and it's just yeast growing on the patient's skin. So these patches may appear either white, pink, red, or brown. And then for common treatment options, again, it's going to be potentially some topical options with ketoconazole shampoo, or we can do Selsun Blue. If they don't want to do that, they can always go to fluconazole 300 milligrams once weekly for 2 weeks for a prescription. All right, so this concludes our presentation. I got one last question, and this is going to be for the win. Actually, I think I have a couple of questions, and then one for the win.
Hey, Dr. Campbell, what's up there?
All right. All right, we got 4 more questions in the last one. Which Canada species is most likely to cause uncomplicated BBC? Alright, perfect, Canada albicans. And which Canada is no flu for the crew? I love it. Okay, heads up, everyone. Back up. There we go. Which factors give a diagnosis of complicated BBC? Recurrent infections, severe infections, non-Canada albicans.
I saw the first one.
No, it's this one.
before you're rushed. Does that make sense?
I've never heard y'all talk this much.
What is tinea pedis? So going to the nail salon, you want to get a what for what? Athlete's foot, fingernail infection, ringworm. Oh yeah. Sorry. That was me. Yeah, you're right. I was thinking fingernail infection. Don't mind me. I was thinking this one. First line treatment for, oh my god, my ghosts. I heard it. Love it! So that's the biggest thing I want you guys to get from that section. Alright, and then I think, alright, so we're gonna see who the leader is, and I got one more question. Oh. Alright. The last question is gonna be the best question. And it is, what is my favorite antifungal? So this is a completely guess. Obviously. Mucosa's kind of basic. For me, I'm thinking more severe infections. So the reason why I love voriconazole is my ID providers are scared of it, just because of all the side effects, the therapeutic drug monitoring, things like that. So for me, it's always a challenge to treat some of those aspergillus species. So, all right. So next, I'll give you to see if yeah.
Who is Beyonce? I don't know.
Alright, so we got the last piles of candy for ZF, so ZF. Alright, and then Beyonce, are you gonna sing for us? And then shout out to Dive Bootcamp for the name. Alright, do you guys have any questions at all? Yeah, it's immunocompetent, not immunocompromised for uncomplicated BBC. So that's a typo.
Where is it?
It says immunocompromised, immunocompetent.
Yes.
If you go to slide 23.
Is that it?
24, sorry.
Yeah, the bottom cut off.
So we have a different bullet point on this one. Should we eliminate?
What is it?
There's an extra bullet point.
This is not
I
absorbed,
crossed it out, but
not absorbed orally.
yeah.
Oh, that was just me. Don't worry about that. You don't have to worry about that. That's not going to affect anything for the exam. Biggest thing I want you to know for this is going to be for fresh.
Everybody good? Alright, so tomorrow we will break off into our groups, we will have class time, y'all can have an extra 7 minutes for lunch today. And then we'll finish our lectures tomorrow, okay? I am looking